Hi everyone, and welcome to the Otolaryngology Clinics podcast. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngology Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the December 2020 issue dedicated to robotics and otolaryngology, guest edited by Drs. Uma Maheshwar Duvari, Arun Sharma, and Erica Thaler. Here now is the consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, I'm Dr. Sujana Chandrasekhar. I'm the consulting editor for Otolaryngology Clinics of North America, and today I have the pleasure of speaking with the three guest editors of the December 2020 issue of Otolaryngology Clinics of North America on robotics in otolaryngology. I'm happy to welcome Dr. Uma Maheshwar Duvuri, MD, PhD, Associate Professor of Otolaryngology at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania. Arun Sharma, MD, Associate Professor and Division Chief of Head and Neck Surgery at Southern Illinois University School of Medicine in Springfield, Illinois, land of Lincoln. And Erica Thaler, Professor and Interim Chair in the Department of Otolaryngology Head and Neck Surgery at the University of Pennsylvania School of Medicine in Philadelphia, Pennsylvania. Welcome.
Thank you.
So we are going to talk about the really excellent articles that comprise the issue on robotics. I'm going to remind our listeners that in the same issue, there is an article series on otolaryngology during COVID-19, which was edited by Dr. Zara Patel of Stanford University. And that podcast is already out, so I urge you to look at those articles and listen to that podcast as well. So let's get started with robotics. I had fun writing my preface because I got to say "Domo arigato, Mr. Roboto," which I didn't think I would be able to quote a rock and roll song in a scientific article. But you know, Erica, Dr. Thaler, the use of the robot in head and neck surgery is the latest in a long series of tremendous innovations in surgery in our field. So how does the story of the robot's incorporation into our field inform the next innovation?
Well, you know, I mean, one of the things that I think is great about ENT is that we've, as a field, you know, we've incorporated, I think, almost every major technical innovation there's been over the 50 years, and including the robot. And I think that it may have been the CEO of Intuitive or somebody high up in their organization who said to Greg Weinstein, my partner, who was very instrumental in developing Torus for head and neck cancer, said, you know, Intuitive aimed for their heart and they hit the prostate. And, you know, head and neck kind of went along on the side somewhere. And I think it wouldn't have happened if one of our residents hadn't been keeping an eye out for technical innovations. And he really pushed, this was Neil Hochstein, he really pushed Greg Weinstein and Bert O'Malley to pursue it at Penn. And, you know, I think that's what we have to do. You have to look out sort of for what's out there all over the place and see how you can incorporate it into our field. We're a group of people who are very smart, even amongst doctors, and I think sort of techie. And so, you know, we should be looking for this kind of thing everywhere.
You know, I agree with you. And I think the difference that I see between the otolaryngologic applications and, let's say, a lot of the GU applications is that, and we'll discuss this as we go further, we've actually been able to show a true benefit to using the robot, both oncologically, for dysphagia, for reduced hospital stay, etc., which, you know, I have to say that data is not as robust in some of the other applications. So Arun, Dr. Sharma, can you give us an idea of what key ideas from the TORS or the transoral robotic surgery story What key ideas from that story can we use to look at future surgical innovations?
Well, I think TORS is a really great example for how surgical innovation can occur. And as Erica said, I think it's a really fun story in terms of how it all came together at the perfect time with sort of the perfect set of circumstances. And when it did come together, there was relatively rapid acceptance. The TORS story brought together sort of existing technology and equipment that was being used in other disciplines. It brought together equipment such as retractors that were already being used by folks in our specialty, and there were some modifications. It brought together a clinical need that was identified, and existing procedures were already there, but doing them with robotic technology allowed for better outcomes. And so, sort of those factors sort of came together to allow for this innovative technology. As a result, there was fairly rapid acceptance within our specialty. But even though it was rapid, the original people who were doing this did a really good job closely tracking outcomes. And initially, a lot of the studies were feasibility studies showing that this was feasible. And then they went on and did studies of oncologic outcomes in terms of things like margin status, functional outcomes. And then following that, there were comparative studies, and there's still some ongoing comparative studies that we're still doing even now. And I'm sure as we keep going forward, it'll certainly continue, and it should continue. So I think the lessons is that it's really helpful to draw on work that's being done by our colleagues in other parts of the body or in other disciplines, because I think we can learn a lot from them. And the other part is to really do high quality clinical research to prove that there is a benefit compared to other surgeries or other modalities for taking care of our patients.
And I think both of you have highlighted the importance of not staying siloed, right? So I think it's not just not staying siloed as otolaryngologists within the House of Medicine, but frankly, it's not staying siloed as head and neck cancer surgeons or sinus surgeons or otologic surgeons within the House of Otolaryngology, because the beauty of talking to each other is this cross-pollination and moving the needle forward for all of us. So Dr. Davouri, what are the indications for robotic surgery in the management of head and neck patients? And I think initially it was really only for primary small, like T1, T2. And I think those indications have expanded to including primary and salvage cases and perhaps a little bit larger cases.
Yes, so it's a very, I think, important segue to what Dr. Sharma was just saying. I think that robotics in many specialties had been considered a boutique operation, or maybe something that was really interesting to do because you could do the same, let's say, prostatectomy with a little bit more sophistication with articulated instruments, but it fundamentally was still a laparoscopic operation. So I think the concept that it really fundamentally changed the paradigm of how we manage prostate cancer or GU cancers, for example, wasn't really there. That data wasn't as compelling. I think in head and neck, we really had no equivalent to a minimally invasive operation to begin with that was widely adopted. And so when robotics came on the scene, as espoused by Drs. Weinstein and O'Malley, it really changed our fundamental perception of how we could take care of these patients. So it's a long-winded answer, I would say, to your question, Sujana. But getting to the heart of the matter, I think there are a couple of ways to treat patients with head and neck cancer, especially oropharyngeal cancer, and that's really non-surgical therapy with chemotherapy and radiation, or primary definitive surgery. So we started this field by offering patients with low volume disease, that is T1, T2, N0 to small n, N1, N2 patients, surgery in an effort to avoid giving them radiation. And we realized that was feasible and possible. However, a significant percentage of our patients present with advanced disease, and so they were treated primarily with definitive chemotherapy, radiotherapy. And then as the field continued to evolve and we had longer follow-up on these patients, we noted that many of these patients failed. And so then TORS became an attractive option to salvage these patients as opposed to performing open surgery, which was the standard of care. So mandibulotomy, tracheotomy, PEG tubes, etc. And by doing transoral surgery, we're actually able to reduce their length of stay sometimes by as much as 80%, reduce the need for tracheotomies. Very few patients end up with tracheotomies now, even in the salvage setting. And this data is very nicely written by Vin Pilleri in his chapter. And as a consequence, we're now expanding the indication. So robotics continues to evolve. And so where we are now is not necessarily where we're going to be in a year from now. So I think the field is constantly moving. But having said that, I think the current indications are really management of low volume disease, of basically staged by the nodal status, and salvage cases. And there's a really elegant video in the chapters written by Dr. Parhar, Ever, and Brody that I encourage everyone to look at to really get an idea of what robotic surgery really means.
Thank you. I think that's really helpful. So, we're talking about disease that is identified and then addressed, but we have plenty of patients who present with a neck disease with an unknown primary or an occult primary. So how can TORS help us manage these patients? How can we take imaging advances, just like you guys were saying from the beginning, like not being in a silo, but using the advantages of imaging, using the advantages in chemo and radiation, and then using this advantage perhaps with TORS. How can we use this to identify the occult primary and then to treat with as minimal negative effect to the patient as possible? And maybe Arun, I can ask you to answer this.
Yeah, so TORS has become commonly used at the same time that we're seeing more and more of these unknown or occult primary squamous cell carcinoma, and that's largely because of the increasing prevalence of HPV-associated cancers or P16-associated cancers, and so they both sort of occurred at the same time, and that was really just fortuitous. We know that transoral lingual tonsillectomy, which can be performed robotically, has a fairly high success rate in identifying the primary site, including in patients who had fairly extensive workup, including pan endoscopy or PET scan. And so even so in those patients where the primary site couldn't be identified with our standard techniques like pan endoscopy and PET CT, we can still use a TORS lingual tonsillectomy to identify the primary site. The other benefit is that if patients are undergoing that procedure and the primary is identified intraoperatively, they can often undergo concurrent resection of the primary and neck dissection if it's appropriate to achieve oncologic surgical treatment. That can help us in terms of tailoring the adjuvant therapy afterwards when we get pathologic data. And that's certainly one of the benefits of TORS, is that we get pathologic staging to help tailor our adjuvant therapy. And in some cases, we can minimize the amount or the intensity of adjuvant therapy. For instance, sometimes we can consider sparing the pharyngeal mucosa if patients have had an appropriate treatment of the mucosa of the pharynx. And that certainly can be advantageous from a swallowing standpoint. I think in all of these cases, the decision-making is fairly complex, so it's always good to have a multidisciplinary team approach, including surgeons and non-surgeons. And so a tumor board setting is great to discuss these cases before we embark on these procedures. And Dr. D'Almeida has a very helpful flow chart in his article for managing the individual who presents with an unknown primary. And he's also identified some good cases showing the utility of modalities such as TORS and PET CT to help identify and treat primary lesions.
So yeah, I agree. I thought the pictures were really worth 1,000 words in this particular article, because it's really guides the TORS surgeon to approaching things from less of a blind perspective and more of a targeted perspective. Just as an aside, we had an issue on the multidisciplinary management of the head and neck cancer patient a few months ago that was guest edited by May St. John from UCLA. In your institutions, other than the surgeon, the radiation oncologist, and the medical oncologist, who else is part of your tumor board? So Erica, maybe we'll ask, what happens at Penn? What other disciplines do you include in your tumor board?
We have a radiologist, a head and neck radiologist, neuroradiologist, who is always there reading all of the films. We have at least one or two, sometimes people from pathology who are, going over path findings, especially anything that's, controversial. We have speech language pathologists who are there. And really a lot of the support staff for the head and neck surgeon. So, these are big teams of people. They're nurse practitioners and nurses who are involved. And so really the whole care team, I would say, is there.
And then do you find, like when Arun was saying that maybe you can reduce the amount of radiation to spare the mucosa, is that, are you finding, all three of you, maybe Uma, I'll direct this to you, are you finding that the radiation oncologist is comfortable hearing the feedback from a speech and language pathologist, let's say?
Yes, absolutely. I think that the radiation oncologists, not only are they comfortable hearing the feedback, but when they actually see the patients in their own clinics and they see that reduced radiation doses are accompanied by significant improvements in quality of life. Yes, it's an anecdotal patient that one sees, but as we all know in medicine, we're often swayed by the very outstanding patient or the patient that did very poorly. Say, oh my gosh, I'll never do that again. But really, the pictures is worth 1,000 words. So the radiation oncologists see this, and I think one of my colleagues said this earlier. We now have really excellent data that's coming out in the context of robotic surgery, especially for cancer. I will highlight data from the Mayo Clinic. There was a trial that they published. The first author was Danielle Ma, which showed that de-escalated radiation postoperatively conferred excellent survival to patients. ECOG 3311, a multi-center trial run through the ECOG Akron Cooperative Group, was recently presented by Bob Ferris, who's a senior author, lead author and senior investigator on that study at ASCO last year. And the paper is currently in review. So as these data start coming out, it allows us to not just talk about the anecdotal patient, but rather the body of evidence that exists to support this hypothesis.
So Erica, building on that, we talk about de-escalation of therapy. And, a couple of us on this call are old enough to remember the days of a big surgeon makes a big incision and, all sorts of craziness that we were trained with. And we have seen in our careers, which are far from being over, that we are really going to smaller incisions and smaller interventions with much enhanced quality of life. And then the big change that happened in head and neck cancer and oropharynx cancer in particular was the HPV, the introduction of HPV as a causative factor. So where do you see the de-escalation of treatment using TORS for HPV in particular?
Well, I think it's beyond just HPV. It's really across the board. I mean, HPV is particularly suited because it has a, its phenotype is different in terms of how things play out, how it behaves. So its behavior is less aggressive, and you can kind of maybe get away with some things that you might not be able to get away with non-HPV squam. But I think that on the whole, the concept of there being a trade-off between outcomes and function. Which, I grew up with, as I'll admit to being one of the older people. I was trained on commando operations and composite resections and all that. And, and even that was considered respecting function at the time, instead of just whacking out and not reconstructing. So at least we were reconstructing in some way. But, we've gone from free flaps being like the latest, greatest thing where you could reconstruct and at least preserve function to now, because the resections are more precise and and able to be done without all this disruption in functionality of swallow and of breathing. It allows you to reduce adjuvant therapy modalities, just as Dr. Sharma was pointing out, for the unknown primary. I mean, that's like a perfect example of where this is really played out beautifully for patients' outcomes. So that's how I see it. I think it's sort of a more holistic thing, and it really actually goes beyond cancer management. I mean, it's true of many of the other applications for robotics as well.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
So I'm Sujana Chandrasekhar. I'm consulting editor for Otolaryngology Clinics of North America. And today I have the pleasure of speaking with the 3 guest editors of the December 2020 issue of Clinics dedicated to robotics in otolaryngology. Dr. Uma Maheshwar Duvuri of the University of Pittsburgh, Dr. Arun Sharma of Southern Illinois University, and Dr. Erica Thaler of the University of Pennsylvania. You can access all of the issues and all of the articles at www.oto.theclinics.com, and you can also access all of our podcasts there or wherever it is you get your podcasts. So let's continue. Erica, I might go back to you. We were talking about these open and maybe not the jaw tongue necks anymore, but the jaw splitting or other operations. How do you navigate the decision on when TORS is applicable? Is it only by T1, T2 tumor size, or are there other criteria that you use to decide that this case is amenable to TORS and this case is not?
I think in general, first of all, I would say that, this decision-making has very much to do with the individual surgeon's training and expertise. TORS is not, it's got a bit of a learning curve. And I think, taking out basically sort of a lingual tonsillectomy, T1 basic tongue tumor is one thing. But some of the more complicated late stage pharyngeal cancers are, an entirely different thing. And you can, get into some difficult situations quickly. So, I think some of it depends on the surgeon's comfort level. Some of it depends on, frankly, the institutional support, what you've got in the way of coverage and who is it when God forbid a patient comes back bleeding, who's going to be on call? Is the anesthesiologist prepared to deal with it? What's your catchment area? These are all decisions that I think play into, they're factors that play into your decision about an individual patient beyond, what's the right thing from the literature. And of course now, Dr. Duvuri was pointing out, there is a robust literature about this now, which will help guide us in terms of what your particular management is. And that's wonderful. But I do think with something as really as complicated technically as TORS can be, that all of those things have to play into it.
So I think those are very wise words, especially if you're starting a program, and especially if you're starting a program without maybe the backup that is there at University of Pennsylvania or University of Pittsburgh or Southern Illinois University. I think that's really wise. Uma, Dr. Duvuri, can we use robotics in children? And what types of issues can we use robotics for in children?
So that's a very timely and appropriate question. So there's a lot of enthusiasm now in expanding the role of robotics in head and neck surgery management of patients that have head and neck problems. So far we focused a lot on oropharyngeal cancer, which is really a common indication for robotic surgery. But robotics is also approved for the management of benign disease. And so thankfully, most of our pediatric patients don't have malignancies of the head and neck, and so that's a good thing. But unfortunately, for those patients that do have malignant processes of the head and neck, robotics can be used to treat those patients. even the pediatric population. And I think the chapter that was written on robotics in the pediatric group, very nice flow diagram that talks about some of the advantages of robotics in this patient population. But to answer your question more precisely, I would say that robotics in the pediatric population has been mostly used to treat benign disease, such as linguotonsillar hypertrophy, benign lesions of the tongue base, such as lingual thyroid tissues or ranulas at rests of the tongue base, usually in slightly older patients. But I have some experience in doing this in very young patients, as young as 8 months of age. So the robot actually, despite its size, is actually applicable for these patients and may have some benefit to treat these patients. It's clearly a very early and, no pun intended, infantile part of our practice and as otolaryngologists. And so the role of robotics in the pediatric population, I think, is really going to be defined much more carefully in the years to come.
Infantile. I see what you did there. That was clever. This is what I love about my life at clinics. I just get to talk to really smart people with clever statements. So Erica, can we talk a little bit about adult sleep apnea and how TORS, not the indications for surgery, blah, 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 for sleep apnea, because that's not the purpose of this, but how we incorporate TORS as one of the tools that can be used?
Well, one of the things that I've learned over time as sort of an evolving sleep surgeon is that, there is no one phenotype surgically for a sleep apnea patient. And the second thing is that the surgical armamentarium for a sleep surgeon is evolving at lightning speed right now. And so that's a great thing, but it's also a challenge because, you don't want to sort of keep moving along and throwing out things that, were good along the way. And that even goes back to, uvulopalatopharyngoplasty. Frankly, there are a lot of people who still benefit from that sort of dinosaur procedure. But I think that, TORS for sleep apnea has a role. It probably doesn't have as much of a role as perhaps I and others thought maybe 7 or 8 years ago, but it is a very useful and very successful part of the surgical decision making in somebody who has CPAP intolerant sleep apnea. So I think that you have to think about things like BMI, like lateral wall collapse on DICE. There's a great table in the chapter on this that Lynn et al. Have nicely illustrated how those factors can really affect your success rate with TORS, where on a scale of 0 to 4, 0 having a surgical success rate of 87%, whereas up to 4 having a success rate really of essentially none, 0. So those things you have to consider. Again, phenotype really matters in this kind of decision making.
So not only phenotype for deciding that you're going to intervene, but then separately for when you're going to use TORS or something else to intervene, which is very interesting. We had an entire issue of clinics on obstructive sleep apnea that was edited by Maria Cerna and Ofer Jacobowitz. So I recommend, if you're interested in that, listeners, go ahead and go back and read that and listen to that podcast. Arun, can we talk a bit about robots and the neck? So can we talk a bit about robotic neck dissection and robotic thyroidectomy? And what are the are we now walking around with a hammer and looking for nails to punch, or are we actually doing something that helps patients?
Yeah, there's certainly quite a bit of patient benefit to both of these groups of procedures when they're done robotically. Generally, they're most appropriate for patients who are motivated and seeking a less conspicuous incision. And so for that reason, it's really important to have very clear patient communication, patient expectations of their options, so that they can make an informed decision in conjunction with their surgeon. When it comes to thyroidectomy, there's a number of remote access approaches, and each of those has its own pros and cons. The one with sort of the longest safety record is the axillary approaches, which have been done for quite a while. Those do have risks to some adjacent structures near the axilla, including the brachial plexus, but the authors in that article do a really good job of approaches or surgical techniques to avoid injury to the brachial plexus. Another approach is the retroauricular or facelift approach, which has the benefit of a shorter dissection distance between the incision and the thyroid. But there are some adjacent nerves like the great auricular nerve and marginal mandibular nerve. Fortunately, injuries to those nerves are usually transient insults. And then the newest is the transoral approach, which has the benefit of avoiding an external or a cutaneous incision. Again, that puts the mental nerve at risk. And there's a theoretical risk of taking a procedure that should be clean and sterile and having oral contamination, even though the research that we're seeing suggests that doesn't seem to be an issue clinically in the series that are out there. And so with all of these approaches, it's good to educate our patients about the options. And we know that these outcomes with these procedures are best when you have an experienced surgeon who's familiar with the approach that they're doing and does a high volume of those approaches. So those are all important factors when counseling patients. And we know that with robotic thyroidectomy that there does seem to be a significant benefit to patient psychiatric outcomes and quality of life. So there is certainly some benefit there, and it's not just a hammer looking for a nail, but I think we really can benefit our patients. When it comes to neck dissection, again, we can do a similar procedure as what would be done through a standard incision, but with a less conspicuous incision. Again, surgeon expertise and volume is really critical to doing this safely. But the initial series do show that patients who undergo neck dissection have longer anesthesia times, especially as surgeons are on their learning curve. And so it's important that if we have a patient who are considering a robotic neck dissection, that they're relatively young and can handle slightly longer time under general anesthesia without any adverse or significantly increased risk. In the article by Dr. Duvori and colleagues, there's a really nice algorithm for when to consider robotic approaches for neck dissection.
So when you started learning or teaching yourself maybe how to do this, Uma, can you tell us about the learning curve? That's always big literature in otology, the learning curve for stapes, the learning curve for this. What's a reasonable expectation for how many cases it takes you to become facile, and for how much extra time is allowable extra time and how much is not?
Yeah, so it's a very important point, Dr. Chandrasekhar. So the learning curve, so I'll start by talking about learning curve for TORS in general, because that's been better studied. And we know that the learning curve to reduce complications such as postoperative hemorrhage, et cetera, in transoral robotic surgery is about 40 cases, 40. Robotic neck dissections required typically the use of 4 arms on the robot, not just 3. So there's an extra arm. So one has to learn how to clutch and move the arms and so on and so forth. So the learning curve for that actually probably is a little bit steeper if you are starting off with robotic neck surgery as your first foray into robotics, which I don't recommend. I think people should start with transoral robotic surgery, gain some expertise and finesse in how to use the robot, and then move on to these robotic neck operations or thyroid operations as the second phase of the learning process. Having said this, Arun is quite right that the operative time is about twice as long to do this robotic dissection, even in the best of hands, even the hands of our colleagues in Korea who have a larger experience in doing this. And we'll talk about this a little bit later on in the podcast about the cost-benefit analysis and how do you really reconcile that with our patients. So I won't get into that at this point in time, but suffice it to say that the time does play a role. It does take about twice as long to do this, but the preliminary data that have been put forward to study this suggests that not only is patient satisfaction higher, that complications such as lymphedema seem to be significantly reduced in these patients, especially in those who have salvage neck dissection. So we can actually do robotic neck dissections to treat patients who have failed chemoradiotherapy. And those are the people that have seem to have the best outcomes and the most benefit from this.
And as somebody who I know the neck is someplace I put some jewelry on at this point in my life, is this an oncologically sound? Again, being a dinosaur and doing radical necks and talking about getting out every single lymph node and getting 6 or 7 levels of lymph nodes out. Is this an oncologically sound procedure and still less lymphedema, less other complications?
The short answer to that is yes. There's great data from Asia, from Korea. They've sort of pioneered this and have some of the greatest volumes of patients that they've reported on this. The North American literature seems to support this. I have published on this as well as other authors. We find that the nodal yield is comparable between open and robotic neck dissections. We also know, based on some really, really strong level 1 data, that you need to take out greater than 20 to 25 lymph nodes on a neck dissection to be considered oncologically sound. So again, going back to your point about doing less operating, right? Maybe you don't need to do the radical neck for every patient that has any head and neck cancer. Maybe you can do selective neck dissection. Maybe for small N1 disease, a selective neck is just as good as a radical neck without the disfigurement and the morbidity that accompanies that operation. So in that vein, we are pushing this envelope forward, but with data, with strong data, driven from level 1 evidence from analyses of randomized clinical trials. And so with that in mind, robotic neck dissections do provide us with adequate nodal yield and adequate nodal clearance as compared to open neck dissections.
Thank you. I think that's really very helpful. I'm Sujana Chandrasekhar. I've had the pleasure of speaking with the 3 guest editors of the December 2020 issue of Otolaryngologic Clinics of North America, Dr. Devori of Pittsburgh, Dr. Sharma of Southern Illinois University, and Dr. Thaler of the University of Pennsylvania. As you know, you can access all of the issues of clinics at www.oto.theclinics.com. You can see all the clinics and the articles there. You can see the related materials like the videos we talked about earlier. And certainly you can access all the previous podcasts there or wherever it is you get your podcasts. So as we're wrapping this up, and this has been really terrific, I think I commend in such a short time people like the 3 of you and others who are leaders in this field, moving this needle forward, as you said, with data and with science and with true demonstrated patient outcome benefits. I know that we can talk a bit about salivary glands and otology and skull base, but what I'd really like to talk about, and because there's some excellent articles on those, and I recommend that our listeners read those, let's talk a little bit about dysphagia. So Dr. Sharma pointed out the inherent difficulties with over-radiating or over-treating at the mucosa in terms of speech and swallow. So Uma, can you talk to us about recurrent oropharyngeal cancer and what can we do in terms of quality of life, particularly with dysphagia as one of the outcomes we're looking at?
Sure. So the standard of care for treatment of patients with oropharyngeal cancer, I would say one of the standards of care is chemotherapy and radiotherapy, usually given together. And we know that chemoradiotherapy tends to cause dysphagia in these patients. And we know that dysphagia can happen many years after the initial treatment. Now, for the patients that have recurrent disease, in other words, those that fail chemoradiotherapy, the options for them are really quite limited. And probably the leading definitive therapy that attempts to really cure this patient is surgery and surgical resection. And this traditionally has been performed with the commando operations and the more invasive open procedures. Now, several groups in the world have tried to use transoral surgery as a mechanism to remove the tumor and to perform oncological surgical extirpation without causing as much dysphagia. And so Dr. Polari's article really delves into this. Now, it's really important to remember, I think Dr. Thaler mentioned this before, that as surgeons embark on incorporating TORS into their pathway, we have to understand that TORS is not a standalone treatment. You don't just do TORS and say, you're done with it. Right? You need skilled rehabilitation therapists. You need speech and language pathologists. You need people to help these patients recover their function after this treatment. And so the dysphagia rehabilitation after salvage TORS requires intensive therapy. And Dr. Polari and his group have really delved into this and put this together. What's really interesting, if I'm just going to take a slight tangent, but I think is really relevant for listeners to hear this, Dr. Chandrasekhar, is that new data coming from MD Anderson Cancer Center has looked at patients treated with primary oropharyngeal cancer, treated with TORS, compared with those that had definitive chemoradiation, compared with those that had TORS followed by adjuvant. So all three modalities, so surgery alone, non-surgery alone, or surgery plus non-surgical treatments. Surprisingly, patients treated with definitive chemotherapy and radiation had the worst swallowing outcomes. Surgery alone was the best. Surgery plus adjuvant therapy was still better than chemoradiotherapy by itself. So adding surgery to chemotherapy and radiation, you'd expect it to cause more dysphagia, cause more problems, but it didn't. So, and this is prospectively collected data. So this is really good data. It was presented at ASCO. I think that this now opens the door for us to do even more studies to really understand if that data is translatable. Is that unique to MD Anderson Cancer Center because of the nature of the organization and the infrastructure that they have to treat those patients? Or is that data truly translatable to all centers? And if it is, I think that will really be a game changer, as you might say, in terms of how we manage these patients.
So I think that's really outstanding. I think as you all three have said, having not just otolaryngologists willing to look at themselves critically and look outside of our field to incorporate new information, but also our colleagues in medical oncology, in radiation oncology, in speech and swallow, really help us manage the entire patient. It becomes a much more personalized management of each patient, even though we are obviously acting within guidelines for tumor stage, nodal stage, et cetera. So I think that's a huge advantage that, as we see within our careers, going from disfiguring poor quality of life treatments to cosmetically and quality pleasing, including speech and swallow, that's with oncologically sound procedures, is really very important. Let's talk a little bit about complications, because there's nothing that doesn't have complications. And so maybe I'll ask Arun, so I can just give Uma a break from talking for a second. How on earth do I interpret a hemorrhage rate that ranges from 1.5% to 18.5%? So how are we counseling our patients? What's the correct way to properly counsel the patients and their families? And I think, Erica made a point of don't forget our anesthesiologists, right? So we're asking them to put somebody to sleep, and we're saying, well, maybe they'll bleed 1% of the time, and maybe they'll bleed, 1/5 of the time. So that's a huge discrepancy, right?
Yeah, so that is a huge discrepancy, and there's a number of reasons for that. TORS is a heterogeneous group of procedures, and so you can have TORS for a very small primary or for a very big primary, or you could have TORS for in the salvage setting. And so we know that the risk of hemorrhage in multiple studies has been shown to be higher with larger resections. It's been shown to be higher in the salvage setting or in a patient who's had prior treatment with either radiation or chemoradiation. And so that's one of the main reasons for the heterogeneity in the hemorrhage outcomes after TORS. I discuss that risk with every patient who's considering TORS prior to surgery, and it's important to, I think, counsel patients and their families appropriately about that risk, which is not insignificant. I also discuss with them that one of the ways that we can decrease that risk is with transcervical arterial ligation, or ligation of the external carotid artery branches that supply the area that's resected. And that's been shown in multiple studies to decrease the risk of severe hemorrhage significantly. And there was actually a recent meta-analysis that confirmed that benefit to transcervical ligation, either done concurrently or prior to transoral surgery. So I think that's an important thing to counsel patients on, and the real take home is that there are things that we can do to decrease that risk of hemorrhage. And another thing to consider is that if there is a patient who has a particularly high risk of hemorrhage and has a high risk of aspirating, you could consider a temporary tracheotomy if you're very concerned, and then plan to take it out when you feel that risk has gone down sufficiently.
So does ligating the branches of the external carotid limit the benefit from adjuvant treatment if you need it, or limit the ability to use any sort of tissue transfer?
So it really does not. There's nothing to suggest that adjuvant therapy is less effective after ligation. And as you know, the blood supply to the head neck is quite rich, and there's a lot of redundancy. And so there's still going to be some blood flow, but you're limiting the arterial flow to that exposed defect in the pharynx. Other flaps that can be used for reconstruction, like uvulopalatal flap or fan flap, can often be done even after ligation of the lingual artery.
So you're really relying on the sort of that diaspora of blood flow as opposed to a single blood vessel for that.
That's correct, yeah.
Very cool, very interesting. So we talked about bleeding. So now let's talk about cost. So Erica, you are in significant leadership roles in your department and your institution, and robots are really expensive. I know the paper in 2009 by Weinstein said 1.5 million for the purchase. I think it's now up to 2 million, hard American dollars for a robotic system. So each piece that goes on an arm has a finite lifetime, right? And won't work. Let's say it's supposed to be used 10 times, it won't work the 11th time. So can you talk to us about, with your perhaps administrative hat on or citizen of the university hat on, should we be thinking about if people are trying to introduce robots or expand their robotic program in their institution?
Well, I think there are a couple of issues. I mean, first of all, the robots are not used by one specialty. So we have a robotics committee that looks very carefully at utilization and really spends a lot of effort to maximize the time that the robots are used, so that each $2 million robot is being not sitting there gathering dust for 4 out of 5 days of the work week, and then one day it's there for tours. I think it's important that the institution has has the full complement of surgeons who are interested and willing to use it. But I would also go back to a comment that Dr. Duveri made early on, which is that I think you really need to make sure that the outcomes are better, and that there's good data that the robotic approach to your procedure is worth it to the patient in terms of survivability is the main thing when we're talking about cancer, of course. And maybe that isn't so true in some of the other indications that are out there in the Urogyn world or others. That I'm not as familiar with that literature, so I can't really comment on it. I will say there was a slightly upsetting article that was written by Zeke Emanuel in the New York Times a bunch of years ago about how robot, and he is from our own institution, about how robots were this perfect example of over technology in medicine and too expensive for not any good outcome. And I think perhaps I would argue that wasn't entirely well informed, and that he's maybe been proven wrong to some degree, but not, he has a point as well. And so I think we do have to be mindful of that as we think about this and really think about, any new technology for the future.
And I think maybe I will leave the final question to to Dr. Davouri, and it's a tough one. Is there a way for surgeons to communicate back with manufacturers? So why should the end instrument only have a lifespan of 10 cases? Like, is there a way for us to intervene so that not as resource-rich communities could potentially take advantage, as we've already said, for better outcomes, better, great surgical oncology outcomes, but great quality of life outcomes. So is there a way to communicate to make those, make it more affordable?
So it's an excellent question. It's a very involved question. There's no easy answer to it. So I'll answer in a couple of parts. Number one, just to take a small step back to what Dr. Thaler said, which I completely echo. I think that when we think about robotics and the value proposition potential of robotics, we have to think about the fact that this is a very early technology. It hasn't been around for that long, relatively speaking. And if we think about the first computer, and as a proud graduate of the University of Pennsylvania, we just celebrated the 75th anniversary of ENIAC, which was the first computer ever made. And it took up the entire room, a huge room, more School of Engineering. And now we have on our iPhones almost 1 million times the power of ENIAC. And if you remember the famous quote, the president of IBM said, well, I think these computers, maybe we'll sell 3 or 4 of them in our lifetime, only to the biggest of users like NASA and DOD and sort of, high, what they consider to be high computing. So what robotics could become versus what it is now is completely Asimovian. We have no idea how this thing is going to evolve. And that's going to trickle down to costs. It's going to trickle down to utility. And so what we're talking about now, just so the listeners kind of have an idea, we're just at the really beginning stages of this wave, in my opinion. I think we're going to see a lot of interesting things happen in the very near future. As we move into this new future, this segues into your question, Dr. Chandrasekhar, which is how do we work with companies to refine these robots so we can make them better? So clearly we live in a capitalistic world. The reason, just to be blunt about it, that these arms have a finite life is because people want us to buy new instruments, right? There's a reason that your iPhone gets updated and revamped and made fancy and shiny so that you buy a new iPhone or whatever company it is. I don't mean to promote one over the other, but the idea is that this technology is going to evolve. But there are several organizations and entities that now currently are industry facing that help our industry partners interface with surgeons or interventionists, medical doctors also, whoever uses these robots to really help the new wave of robots be more valuable and be more useful. There are going to be about 79 new robots that are going to hit the market in the next 5 years. And I'm the head of our system-wide steering committee. So I'm in charge of the robotic acquisitions through the UPMC network. I should say I play a role in thinking about the acquisition of robots in the UPMC network. We have invested now in a robotic bronchoscope. We've invested in robotic technologies that are not intuitive based. We've invested in upgrading our fleet of robotics in intuitive. So there are going to be so many things coming on the market that large institutions like the University of Pennsylvania, like the University of Pittsburgh, like the Weiss Institute at Vanderbilt, there are several entities, even in Pitt, we have an entity called Pittsburgh Creates, which is industry facing, are working with companies to tell them, hey, this is what you need to think about it. Don't make a robot be worth $2 million so that nobody can afford it. We need to make it cheaper so that more people can afford it, so that it can be disseminated to less resource, how do I say this, to more resource constrained environments. think about developing countries, not just the developed first world countries, because reality is that if we had robotics humming at the level it should, we would be able to, what I think of as democratized surgery. You shouldn't be getting better quality surgery just because you're fortunate enough to live in a country that can afford to spend more per capita to take care of a person. If you could actually interface these robotic platforms, you can actually potentially do surgery in a less resourced country by sitting at a console somewhere else. And my colleague Mehran Anvari, who's at the University of Toronto, is actually working with NASA to develop robotic platforms that can operate on the shuttle to Mars and on the shuttle to the moon, right? Because what if an astronaut gets sick on the way to the moon? What do we do? What if they get appendicitis? We can't bring them back. So this is where I think the true value of robotic lies in expanding the reach of surgery, literally, and being able to do surgery. And I know that this sounds a bit fantastic, and it is, but I really do think that this is the untapped need. And once we explore that, then I think we'll have truly a metric by which to measure the value of the dollars spent on these robotic platforms. And while I agree with Dr. Emmanuel's analysis on a superficial level, I think a deeper dive will expose some of these nuances that I think need to be evaluated in the near future.
Thank you so much. That is the perfect note to conclude this podcast with. I'm Dr. Sujana Chandrasekhar. I'm consulting editor for Otolaryngologic Clinics of North America. I've had the distinct pleasure of speaking with three of my friends and colleagues who are the guest editors of the December 2020 issue of Clinics on Robotics in Otolaryngology, Dr. Uma Maheshwar Duvuri from the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania, Dr. Arun Sharma, who is from Southern Illinois University in Springfield, Illinois, Dr. Erica Thaler, who is professor and interim chair in the Department of Otolaryngology at the University of Pennsylvania in Philadelphia. Thank you so much, or as I might want to say, domo arigato. And thank you so much for putting this together and for spending your time and sharing your wisdom today.
Thank you for joining us for this edition of the Otolaryngologic Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on robotics and otolaryngology, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access, as well as individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Otolaryngologic Clinics podcast on Apple Podcasts and the Google Play Store.